Hello and welcome to this afternoon's Ask the Expert session. We put these sessions on once a month for people with PSC and people affected by PSC as well. So welcome to the webinar this Saturday afternoon. I don't know about you, but I've had a really busy morning, as we were just talking about, with ferrying my children around to their various activities. So to sit down and bring you this webinar now is a really nice thing for me to do, and I'm hoping that you get what you need out of the webinar as well. My name is Paula Hanford. I should have said that. I'm the CEO of PSC Support, and just to remind you that all of our Ask the Expert sessions are available on our YouTube channel, which you can go back, you can re-watch this session, or you can watch our other sessions in the past, or any sessions that happen in the future that you can't make live. We have 60, last time I looked, we had 64 people registered for this webinar. So we've got plenty of people on the call. And one of our regular speakers and a great friend of PSC Support is Dr. Deepak Joshi. And Dr. Joshi will be answering your questions on PSC this afternoon. Dr. Joshi is a transplant hepatologist, and he's a lead for Pancreatico-Biliary medicine at King's College Hospital in London. Today's session is a question and answer session on all things PSC. So please put your questions in the Q&A section of the Zoom webinar. We've had some questions emailed to us prior to the webinar starting, and I will take those questions initially, but I want to take as many questions. Hopefully we'll be able to take all of the questions you ask. So please put them in the Q&A section, and throughout the session, you don't have to do them at any particular time. Just keep putting them in, and I will come to as many of those as I can. Please keep them quite short if you can, so we can take as many as we can. And as always, Dr. Joshi cannot give individual medical advice, but will answer your questions in the best possible way that he can. So, as always, Dr. Joshi's got a very busy family life, very busy work life, but, he's given up his time this afternoon to join us. And I'm sure you will join me in thanking Dr. Joshi for that time, so much for giving up his time today. So welcome, Dr. Joshi.
Thank you.
To this webinar, and I'm going to take the first question, if I can find them. So the questioner has got, I think, I'm trying to kind of make a little bit sense of the question, but thickening of the bile duct walls, and it looks like they're due to have an MRCP. How often is cancer diagnosed in such a case?
So, as we know, PSC affects the bile ducts. It can be within the liver. They're called the intrahepatic ducts, and it can be the main bile duct that exits the liver, which is called the extrahepatic bile duct. So if there is thickening there, it's quite a common finding in PSC. So having a MRCP and MRI will look at that area in a bit more detail. The worry with PSC always is, is there a cancer? And the MRI will be able to assess that in a bit more sort of detail. But what that MRI, the MRCP will do, or what should happen next, is that it should be reviewed with previous scans, previous imaging, in a specialist meeting with radiologists, surgeons, clinicians like myself, and then a decision should be made. Has this changed? What's the relevance for this individual with their symptoms, and how should they proceed? So, it's a snapshot. It probably should be repeated every, I'd say, 12 to 18 months. There's no set guidance on that at the moment, and it's a bit ad hoc, but it's about looking at what it looked like previously, and then seeing how we move forward.
Oh, Paula, I think you're on mute. You've just gone on to mute.
I went on to mute. Thank you, Maxine. I did go to mute. My boys are like elephants upstairs, even though they've been told to keep quiet. So I put that on mute. Apologies for that. I've just had somebody say hello from a cold, rainy and windy Poland. So hello. Thank you very much for joining us today.
Or as they say in Poland, dzień dobry.
Oh,
But that's the only Polish I know. I'm just going to say that.
well, that's brilliant. It's much more than I know. This question is, what are the recommendations in the management of PSC IgG4? And if you could explain what IgG4 is, that would be really useful too.
Okay, so IgG4 disease is a multi-systemic, so it affects lots of different organs. It can affect the pancreas, the bile duct, the salivary glands, the lungs, and it's a inflammatory condition. So when it occurs in the organ that it's appearing in, you usually get an inflammatory sort of lesion or an inflammatory mass. So classically, it's in an older sort of population. So when you see that for the first time, like a mass, wherever it may be, people worry about cancer. Now, one needs to be able to take a biopsy of that area, and then you make the diagnosis, and the treatment is with steroids and immunosuppression. Now, IgG4 levels have been sort of you can test it in the blood. And in IgG4 related disease, the levels can be high, but in other conditions, in PSC, PBC, so primary biliary cholangitis, people have looked at IgG4 levels as well, and it can be raised. That does not mean that you've got IgG4 disease, but it's something which has just been tested. And when we meet patients with PSC, or we're making the diagnosis for the first time, IgG4 disease could be a mimic or something that you have to exclude. So it's important to look for it and then exclude it, because the treatments are very different.
Okay, thank you for that. And if somebody has low IgG1, which is obviously a reduced immunity, my understanding is IgG1 is the most common antibody in the human body. What is the significance for PSC patients in that case?
So actually, when we've looked at our own data and people have published before, usually IgG tends to be raised. So if people have got colitis as well, it can be a reason for it to be raised. It doesn't necessarily have an implication on the PSC disease itself. At the start, when when you're making the diagnosis, you need to make sure that if the liver blood tests suggest other diseases, like sometimes you can have an overlap with autoimmune hepatitis as well, that you check the IgG, you check the autoantibodies as well, but we don't routinely recheck it every time.
Okay, thank you for that. This question does come up quite regularly, but I think it is a very valid question. What vitamin and mineral deficiencies occur in PSC patients?
So I think probably vitamin D deficiency is very common. I think, first of all, in general, in the population in the United Kingdom, because we lack sunshine and sunlight for a lot of the year. And then when one has a chronic liver condition, and particularly a cholestatic liver condition like PSC, vitamin D deficiency can be more common. So, I would certainly check vitamin D levels in all my patients, just to see what it is as a baseline. A simple way for an individual would be just to start taking a supplement, a vitamin D supplement, or a supplement that has vitamin D in it. Very easy to buy over the counter. It doesn't have to be prescribed. And then the other things we would normally check for are B12, folate as well, and they're very easily checked. And I suppose if you're ever worried about specific mineral deficiencies, taking a multivitamin, having a well-balanced diet should negate all of that in the first instance.
Okay, and this is thank you for that. The next question is about SAM-E supplementation. Supplementation, which do you know what that?
No.
I did look it up before the webinar started, and it's S-adenosyl methionine supplement.
Okay.
Does that make any sense?
So I think not really. I mean, it's not something we prescribe. Methionine sometimes, there's it's sort of in the liver does a lot of sort of antioxidant work and things like that. So there's a theory that it could help with the liver. Other things people sometimes take are milk thistle, which theoretically has a potential benefit, but with a lot of sort of supplements and things, there's no big data to suggest that this will improve your liver or maintain your liver. So it comes down to individual preferences and individual beliefs. So as long as it doesn't cause any harm, you just need to be a bit wary of that.
And would you always suggest the questioner has said that there's a study underway in Poland in patients with PSC with SAMe.
Yeah.
But would you suggest generally that people should check with their clinicians before they start
Yeah,
taking?
I think so. Now, if there's a big study going on and that is being conducted in a sort of trial-like environment, then yeah, no, it'll be important to see. And like I said, we'd never dismiss it, but you should let your clinician know, your team know, because if your liver blood tests jump up or things change, like you get more episodes of cholangitis, then it's important for them to know as well.
Okay, that's great. That's great advice. Thank you for that. So this question is a little bit long, but not too long. So I'm currently doing a dilation therapy. I need to do an ERCP every 6 to 10 weeks. Every time after the ERCP, I get antibiotics. And they're worried about the immense quantity of antibiotics that they're given. And the question is there any data that the prophylactic prescription of AB decreases the risk of post-ERCP cholangitis? And has it a negative effect on PSC itself?
So with the ERCP, the sort of only sort of absolutes when we're looking after patients with PSC is that all patients with PSC who are undergoing ERCP should have prophylactic antibiotics. And the reason being is, the nature of the disease, you're instrumenting a sterile sort of environment. So you're going into the bile duct. In this individual, it sounds like maybe for the second or third time, but you, in theory, are introducing infection. The other thing you're doing is you're injecting contrast and you're manipulating all the sort of things that are there, and it increases your risk of cholangitis sort of after the procedure. So you should have antibiotics before and after, and I think that would be an absolute. I don't think there's any hard data to suggest that it will change, it will make your disease worse. And if you're just having like a short, sharp course of antibiotics peri-procedure, then I think that individual will be fine going forward.
Okay, that's great to know, and I'm sure that puts their mind at rest. Question about is fatigue normal? I think I certainly know the answer to that, but it'd be great to get your take on that. What can be done about the fatigue? And I'll leave you answer those two, and there's a supplementary question as well.
So yeah, I think fatigue is very common. If we talk about sort of non-PSC factors, first of all, most individuals have got busy lives. You're trying to balance your family life, your working life, and then you have a chronic condition on top of that as well. So I think that alone is fatiguing or tiring. And then if you add on a chronic illness like PSC, there will be times where you can have maybe low-level cholangitis, which obviously, again, can make you feel more tired. There may be certain vitamin deficiencies. And then if you have colitis as well, there's lots of different reasons. So, I think fatigue is probably one of the hardest things to sort of manage as a clinician. We can look for vitamin deficiencies for things which are obvious, but a lot of time they're inevitably normal. So there's certainly a psychological aspect as well. So fatigue is very hard, but I would say it's very common in PSC and in liver disease in general.
Thank you for that. And the other question the poster has asked is, will PSC always lead to liver failure or cirrhosis? And I know this is a question, particularly when you're first diagnosed and you look on the internet, because everybody does. Unfortunately, we tell people not to. That is a question that really comes up quite a lot.
Yeah, I think it's what everybody's sort of worried about and scared about, and I think that's only natural. Whenever I meet patients for the first time, I think it's about making an assessment of their PSC. So symptoms are very important, and then trying to address the symptoms, making sure that if they have inflammatory bowel disease, that's optimized and treated, and managed in the best way possible. Looking at their MRI scans, looking at their fibrous scans, looking for, do they have sort of scarring and what level it's at, and then putting it into the context of them, their age, and potentially other illnesses that they may or may not have. What I would say is not everyone needs, not everyone develops liver failure, not everyone needs a liver transplant, and it is very individualized. But it's about having those conversations with your clinician and saying, well, what do all my tests show? Are you thinking about a transplant? And it can be very hard to predict that. But I always sort of draw an imaginary scale and say, if transplant's here and this is sort of no transplant, and I'll sort of try and put it along that way. Not very scientific, but I think it's about being honest. It's about giving all the information to the individual, and if things are changing, then saying, well, I think we do need to think about a liver transplant assessment. So it's just about that dialogue you need to have with your clinician.
Okay, thank you for that. And another question is, does PSC have different stages in the disease development?
Yeah, I think it's not sort of excuse me, classified per se, but you can have somebody with mild scarring, and this is where their fibrous scan, or if they've had a liver biopsy, can help you, moderate or severe. And then I'd sort of stratify patients according to their symptoms. So do they have itch? Yes or no? Are they getting sort of recurrent infections of the bile duct, i.e. recurrent cholangitis? And also just trying to sort of put them, not necessarily box patients, but understand what their predominant symptom is, and then how do we address it, as opposed to just putting it all together and saying, oh, you've just got PSC. I think that's just, we need to be a bit more sophisticated, and that way you can then look to sort of enroll patients in specific studies, or see what their need is essentially.
Okay, thank you so much for that. Question here about high cholesterol. Is the high cholesterol seen in many PSC patients the same LPX seen in PBC patients, or is it more harmful? And does it present an increased cardiovascular risk?
So commonly in cholestatic liver diseases, so PBC and PSC, you can get raised serum cholesterol, and it's the sort of breakdown of their cholesterol. Now, with certain individuals, you have to treat the cholesterol, but it doesn't generate the same kind of cardiovascular risk as if, let's say, a 65-year-old individual who's diabetic and has high blood pressure. It doesn't generate that same kind of risk.
I think that's reassuring for our patients to know. A question about research. Well, it's about bezafibrate, actually. I've read that some of the latest research in the US recommends that PSC patients with slow progression would benefit from a low dose of urso combined with bezafibrate. Is this something that might be offered in the UK? My PSC specialist won't prescribe ERSO. We know that that's patchy throughout the country, the ERSO, if you get ERSO or not. As my LFTs, sorry, I'll just start that sentence again. My PSC specialist prescribed ERSO, as my LFTs are still in the normal range.
Yeah, so I think, with ursodeoxycholic acid, the data to show that it changes the disease progression or helps improve things is lacking in PSC. So, some clinicians will start ERSO. It's a safe drug, it's a cheap drug, very few side effects. But the question is, if it's not helping, then why are we prescribing a drug? The bezafibrate, there's some data to suggest it certainly helps with itch, and the European guidelines, the ESA guidelines, do recommend that bezafibrate now is the first sort of port of call if you have severe itch. Now, I don't think there's sort of huge data to say ERSO plus bezafibrate will completely treat the disease. And what I would do is I'd almost turn that question on its head and say, if you're looking for research and things like that, then you should be contacting your clinician, your specialist, and saying what trials are available, how do I sort of participate, and then you can get access to newer drugs, which might be part of the answer, but only time will tell after those studies are done.
Can I just thank you very much for that. And can I just remind everyone that all of the live clinical trials are on the PSC support website. So if you would like to take part in any clinical trials, you can check your eligibility and speak to your healthcare professional. Please do have a look on our website, because we always have the most up-to-date ones on there. This is another question about supplements. People are very keen to help themselves, I think, with PSC, quite understandably. I was told by my PSC specialist 18 months ago that coffee, and we've heard that time and time again, that coffee is beneficial, but also turmeric would be beneficial. I understand that some recent research has stated that turmeric should be avoided in individuals with bile duct inflammation and liver disease. Can you give us the
yeah. So turmeric basically has antioxidant sort of benefits and is used a lot in Ayurvedic medicine, which is an alternative medicine, so from sort of the Indian subcontinent. I think coffee, there is some data it can suggest that it can reduce scarring, fibrosis in the liver. I'm not sure about turmeric. I don't think taking a spoonful of that, etc., is going to prevent disease progression. And again, there's no sort of big studies to say it will potentially cause more harm. But I think if we're talking about how can we improve things, a well-balanced diet, reducing or omitting alcohol if you want to sort of avoid any other added sort of insult to the liver. Smoking, although it doesn't have a direct sort of effect on the liver, I think is stopping smoking can be beneficial to your blood pressure, to your heart, your skin, and your wallet, and everything else in general. So I think it's about lifestyle. Exercise can help as well. So it's all these other things that we can do whilst trying to find something like turmeric which will solve all the problems, which I don't think it will, unfortunately.
It's anti-inflammatory, isn't it, turmeric?
So yeah
kind of, in a broad sense, kind of makes sense. But yeah, if there's no evidence, then it's probably, as you follow your guidelines, as you just said. The question here, not about supplements, but about dietary restrictions, actually, to help PSC. Do you recommend any? Low sugar, low carb, A2, or no lactose dairy? Question mark.
So I think that needs to be taken into context. If the individual has inflammatory bowel disease, sometimes certain types of foods can make their inflammatory bowel disease worse or increase their stool frequency. But again, I think it's down to the individual and what they want to do. Again, there's nothing that you have to take. There's nothing that you have to omit from your diet. But having a well-balanced diet, carbohydrates in general, is not good to have a sort of carbohydrate-rich diet. But it's about protein, making sure that you're hitting your energy requirements as well. So I think the emphasis should be on balance.
There's another question about diet, actually, if I could ask that. I saw somewhere that a fasting mimicking diet could trigger, I think could trigger something called
autophagy.
Autophagy, yeah. And I've come across this just in my own kind of life and research about health. And it makes the body break down and reuse old cells. Can this help slow down PSC?
Again, I don't think there's any hard data on it. This sort of comes on the back of intermittent fasting, where you're fasting for up to 16 hours of a day, and what you're doing is you're sort of, like you said, breaking down older cells, etc. I don't think there's any data in PSC, but I think again it just comes down to individual lifestyles. If you want to try it, there's no harm. It will probably help with your weight. It could help with your glycemic control, which all subtle things help your body as a whole, but it's not necessarily going to help your PSC or sort of slow down the PSC necessarily.
Thank you for that. Question here about FibroScan and FibroScan suggesting cirrhosis. So I'll read it out. Do we know the percentage of patients where a FibroScan result suggests cirrhosis and that is not correct? I've been advised that FibroScan results with PSC aren't always accurate. My son had a significant change from the one he had done in Australia last year and the recent one done here.
So most people on this call may have had a FibroScan. It's worth just mentioning a FibroScan is a sort of special kind of ultrasound scan. It's a non-invasive assessment of fibrosis, of scarring. Now, with any test, you can get false positives or you can get false negatives. And it's about putting it, for the team looking after that individual, putting it into context. So the sort of cutoff for cirrhosis, advanced scarring in PSC with a FibroScan is about, I'd say, 14. So if your reading comes back very high, let's say above 14, your team needs to sort of, try and understand, is that in keeping with this individual's disease, i.e. does their, symptoms, does their imaging, their CT scan or MRI scan suggest that as well? What do their blood tests suggest? And like I said, sometimes you can find people where it doesn't quite make sense. So you have to repeat other things. So you might repeat the scans again. And then sometimes you get sort of abnormal readings. So if you've got cholangitis, you can get a high reading. If your liver blood tests are particularly raised, you can get abnormally high readings. And it might be that you just need to repeat the FibroScan. So I'm not sure I can answer what percentage do we think, etc. But it's making sure that like any test, we all undergo is in keeping with what we think is going on, or things do change and then you react differently as well. But then that's why you have your specialist teams to be able to put that in context for you, and then if things have changed, then you sort of move on to the next stage as such.
Thanks, Dr. Joshi. This question, so we know that PSC care and monitoring is not consistent in the UK, which is why we have these sessions so people can advocate for themselves and push the best practice to, in their centres for themselves. So the question is, why is PSC care and monitoring not consistent in all the UK PSC specialist centres? I'm concerned that my hospital only provides MRCPs every 2 years. I thought the bile ducts could only be seen on an MRCP, and worry that cholangiocarcinoma and or dominant strictures won't be picked up at the earliest opportunity. It's a big worry in the PSC community.
Yeah, I think that concern of cancer is shared by the clinicians as well. So I think if we just take a step back, the studies that have been done at, surveying for cholangiocarcinoma in PSC, the studies that have been done so far have not shown a benefit of surveillance looking sort of, with MRI every 18 months, 2 years, etc. But what it can do, it can find these dominant strictures where there's narrowing in the bile ducts, and that might be a precipitant for an ERCP to stretch and dilate those strictures, or potentially sample it as well. So I think the MRI scans are good for that, and in theory, if you find strictures earlier, you can treat them, and then you can sort of limit sort of progression of the disease, the progression of the sort of scarring that goes with the biliary disease. But going back to the question is, why is it so different? I think it's just, the way we've sort of evolved as, different units, different nations. But I think we're getting better and it's becoming more unified. There's a lot of work being done by Basel, which is sort of the British Association for the Study of Liver Disease, the BSG, which is the British Society of Gastroenterology, which also incorporates liver, trying to standardize care, to make sure that all patients, get equal sort of, access to assessments, but also treatments. And then the work done by the PSC support as well, I think, make sure that patients, if, they realize that maybe things are different, they can approach their clinicians and say, well, actually, why can't I have this? Or, do I have access to that? So I think it's getting better.
Yes, yeah, that's great. Thank you so much for that. You mentioned alcohol previously, and this is a question about alcohol. In terms of limiting alcohol consumption for PSC patients, is having 5 to 10 units of alcohol per week acceptable? I have both PSC and UC diagnosed after initial acute cholangitis episode 18 months ago, but I've no symptoms of either since.
So I think, alcohol is predominantly, broken down, detoxified by the liver. So in theory, alcohol is an irritant to the liver, but for this individual, it sounds like, since their initial diagnosis, they've been well, no further cholangitis, and their colitis is managed as well. So I think, the recommended limits for all adults is 14 units, and they're way below that. So is it acceptable? If they were my patient, I would say yes, it is. But for somebody who has advanced PSC, I would say no, it's probably not acceptable. Then they should stop, because it just takes away one less irritant to the liver.
Thank you. This is a question about transplant. I've had great support pre-transplant from coordinators. However, after surgery and discharge, I've not been able to get help responses from that team, which is very worrying, and I know it's not uniform across the country. Appreciate there are resource issues, but I've struggled with donor liver challenges such as infections, stricture, dilation, and other problems, limiting me significantly. Can you explain what support we should expect post-transplant, and how to manage if it doesn't happen? I've tried to find other routes, but difficult and stressful.
I think, after a transplant, things, unfortunately, the disease can reoccur. But what I would say to this individual is I would, persevere with the transplant coordinators. They will have a consultant as well, an allocated consultant, and they need to sort of feel like they are supported. I think with, obviously any kind of setbacks like infections or strictures, etc., it can be taxing, sort of psychologically as well. So asking the teams to access psychological help as well, I think would be very important there. Some transplant centers have, again, patient forums like this, and that may be suitable as well.
Thanks, Dr. Joshi. Somebody's asked on, it's a question for me really, can we see the question of others and can we see each other's kind of faces on the webinar? Oh, and we do keep these anonymous because of people's, you know, other people don't want to be seen or don't want to use their have their names in public. So we do keep them anonymized. So I hope that answers your question there. This is a question about using Spyglass during an ERCP. If you could explain what Spyglass is as well, that would be fantastic. What are the benefits, disadvantages of using Spyglass during an ERCP that has been done for balloon dilation and the relief of pain, nausea symptoms?
So people on this call, some may have had an ERCP. So ERCP just uses X-ray and obviously an endoscope to get down to where the bile ducts drain out. And we use a 2D image after injecting contrast to look at the bile ducts, make an assessment, and potentially provide treatment. Now, what Spyglass is, it's a commercially available cholangioscope. So it's a very tiny sort of scope stroke catheter that you can pass up into the bile duct. It's about, I'd say, maybe 4 millimeters in diameter. So very small, but it's now fully digital. So the pictures that you get as you would do with your colonoscopy or with your gastroscopy. So the images are amazing. And I was doing a case just yesterday on a patient with PSC. And the biggest advantage is it allows you to see inside the bile duct. So, you know, if this individual is having a spyglass, it might be to interrogate a stricture. So you can look at the stricture, you can make an assessment of what it looks like, you can target biopsies as well. And also in certain individuals where the strictures, the narrowings are very tiny, you can actually, under direct vision, pass a very fine guide wire through that area to allow you to get across it as well. Now, not every PSC or you know, every PSC. No, let's try that again. Not every ERCP in patients with PSC requires spyglass, but you know, that individual, if there's a stricture you want to sort of assess, that it may be relevant. Sometimes patients can form stones as well, so you can sort of zap these stones and, you know, sort of fracture them and then pull them all out as well. So there's lots of benefits, but it's not always needed.
Okay, thank you very much for that. The question here, what is the difference between having PSC of intrahepatic bile duct and the ducts outside of the liver? Is one worse than the other? Make it more likely to get advanced liver disease and require transplant?
So that's obviously the, you know, the different patterns of disease. I wouldn't necessarily say that one is worse than the other, but if we again put our ERCP hats on, accessing the extrahepatic bile duct, the one that sort of exits the liver, is much easier than sort of accessing the bile ducts, which are sort of further away within the liver. And I always think of the bile ducts, if you think of a tree, so the extrahepatic bile duct is like the main sort of trunk of a tree. It's going up, and then it branches off to the right main branch and the left main branch. And then like a tree, you have smaller branches, even smaller branches, and then eventually you get to sort of like a bud. Now the bud in sort of the liver would be within the liver cells, so technically microscopic. But you know, if you imagine the sort of bile ducts like that, so the further they are away, the harder they are to access. But I don't think it necessarily means one has more aggressive or advanced disease or is going to be more problematic.
Okay, thank you for that. Question again, another question about ERCP. Are there UK PSC guidelines for the use of ERCP in PSC? And if so, what are they and where can I find them written down?
So there are, excuse me, there are UK guidelines. So this is the British Society of Gastroenterology guidelines on the management of PSC, which I think are from 2018. And if you type that into Google, I'm sure they will come up. And they talk about where ERCP should be used or should be considered. There are also European guidelines. from 2017, specifically about endoscopy and ERCP and PSC. And then there are European guidelines on the management of PSC from 2022. Now, we are in the process of updating the UK guidelines, and I think I will be involved with those guidelines and certainly looking at the role of ERCP. But, I think if you're being offered an ERCP, speak to your clinician, to speak to your team and ask them, what's the target? What are we aiming to do? And I think that's reasonable to have those discussions, because that is the consent process, where the team are proposing a treatment, but also have to propose other options or alternatives as well, and then they go through the procedure with you as well.
Thank you for that. So, question about the transplant waiting list, which, once somebody goes on that wait list, it is a very traumatic time, waiting for that call. And the post is saying, I'm currently on a transplant wait list and I'm well at present, which is great news. With wait times being as they are, what's the longest time you're aware of a PSC patient having to wait for the operation?
So again, what I would say, in the UK, when patients go on to the liver transplant waiting list, they have a score that's calculated. It's called the transplant benefits score, and it takes into account the severity of that individual's disease. So it looks at blood tests, but it also tries to take into account what type of organs this individual can sort of receive. So individuals, of smaller stature like myself could get away with maybe a right lobe, which means it's a split, compared to somebody who is maybe 80, like over 100 kilograms, who might need a full liver. And it just depends on what that individual is, sort of what organ they are sort of listed for. I think, some people have waited a very long time, over 2 years. Some people have waited, sometimes 6 to 8 weeks. But the whole point of the national waiting list and the transplant benefits score in the United Kingdom is that it identifies those who need it the most, and will benefit from it the most as well. So sometimes we will put people on the list, and we feel we can wait for a more optimal organ that suits them, because what you never want to be with transplant is obviously too late. So it's as long as that individual is well, I think that's a good thing, and you do accrue a bit of time then on the list as well.
Thank you for that. Can I ask a question about live donors? What is the percentage of live? Because that feels to me that it's not being maximized.
Yeah,
that is true, isn't it? It's not being maximized in the UK. What percentage? Why isn't it maximized? And what percentage of current transplants are from live?
Yeah. I mean, you're absolutely correct in that we don't have many living sort of donor or live related liver transplants in adults. In children, it's very different. Often it's the parent who comes forward. They can donate, if the child is very small, they can donate their left lobe, which is a smaller lobe normally, and then that liver grows with the child and sort of works for them. I think as a nation we've just been very, I don't know, slow to sort of try and think about living related. There's also the logistics of living related as well. So for essentially you need 2 transplant teams. So you need a surgical team, a surgeon, the sort of assistants, the sort of all the things that go around one surgery. You need it twice as well. So there are the logistics of having the availability of 2 theatres running at the same time, 2 surgical teams running as well, and sort of all the things that go with it. I think it's something we need to work on, and we're lucky in a way that we have a good transplant program outside of sort of living related in the UK, but that can be an option. So again, if you are being considered for a transplant, you know, you're obviously going to be talking to your family. You can speak to them and see if there's anybody who's suitable to donate. And it is an altruistic sort of gift that this, you know, the donor is sort of offering a part of their liver, because they get no benefit from it whatsoever. Now, you can say you did for love, you did for your loved ones, you know, they do it for me, but it is altruistic and there is a risk. But, you know, I think, you know, have those discussions with your transplant teams and say, you know, there may be a potential living related donor. We would always assess the individual first and define their candidacy, and then the donor can be worked up as well. So there's no harm in asking about it, either amongst your family or with the team that you're under.
Thanks, Dr. Joshi. We know that people with PSC have, I think it's 70 to 80% of people with PSC have also got inflammatory bowel disease. I mean, this question is, why can inflammatory bowel disease cause PSC? Does it cause PSC? Why can it cause PSC?
So I don't think we can say that it causes PSC, you know, inflammatory bowel disease causes PSC, because there's a number of patients with PSC who don't have inflammatory bowel disease, or vice versa, they have inflammatory bowel disease and there's no evidence of PSC. So, but they do go hand in hand. And some of the theories that, you know, people have proposed is that you've got a very inflamed bowel, and all of that blood from the inflamed bowel eventually comes back to the liver. And, you know, is it the trafficking of sort of inflammatory cells from the gut back to the liver that causes PSC? And, you know, different groups around the world have looked at it. They've provided targeted therapies. What we do know is that in individuals with PSC and inflammatory bowel disease, their IBD, their inflammatory bowel disease, needs to be optimized. It needs to be treated the best way possible, because that does impact on PSC, both before a transplant and also after a transplant as well. So, you know, if you have IBD and it's not well managed, then, you know, you need to highlight that to your team, and that needs to be optimized.
Thank you. Somebody's asking if you could repeat where to view the UK guidelines for ERCP.
So if you type in something along the lines of BSG PSC guidelines 2018, type it into Google, it should come up.
Thank you. And there's a sort of supplementary question which I didn't spot earlier about the risks of a living donor, living donation, other than the surgery risk. What are the risks to both, I think, the beneficiary and the donor?
So for the donor, they are obviously, there is the risk of the surgery, so bleeding, infection, you know, potentially a bile leak as well. We do quote for death as well. Now, before somebody donates, essentially the donor undergoes the same assessment as a potential recipient for a liver transplant. So they have full assessment of their heart, their lungs, their kidneys. They have imaging, you know, to sort of map out their liver, their volumes. They have fibrous scans. All these things are done before. And it's about making sure that they have no hidden illnesses that they just don't know about. After the surgery, the biggest thing is usually pain. And that is usually managed with an epidural, with a PCA, so that's a patient-controlled analgesic button. And the donor, you know, because it's an altruistic sort of donation, they are looked after by a whole separate team, and real emphasis is given to the donor, because, like I said, you know, they're going from a perfectly fit state to donating their liver. But usually they're out of hospital, I'd say, within 10 days or so, and there's no long-term risks to that individual if, you know, everything has been assessed before and been done in a proper way. For the recipient, it's as per standard, you know, transplantation, you know, sort of risks, but the benefits are there. I just want to quickly go back to the ERCP question. I think there is a video I've done previously with the PSC support, which is available. which goes through some of the indications for for ERCP, what it involves. There's pictures, there's videos as well. So that might be a good place to start as well.
Yeah, so that's on our website. Thank you for the
Yeah.
reminder. We just at the we're running out of time a little bit now, but just on the last few questions as well, and I think we've answered most of them. So thank you so much for that. With a FibroScan, if you have what is deemed mild scarring, what are the chances that this can be reversed / remain at a similar level over time, or is it more likely to ultimately get worse and have more scarring to occur over time?
So, sort of moderate scarring, we're sort of looking at, levels between maybe 8 and, I don't know, 13. I think it's about assessing that and reassessing it. So every 12 to 18 months with a repeat FibroScan, optimizing all the aspects that we can, which we know influence PSC. So making sure the IBD is well controlled, seeing if there's a clinical trial that you can participate in. And then as and when new treatments will arrive, and I think they will, hopefully within the next sort of 2, 3, 5 years, being sort of having access to that. Obviously, there is a risk that, disease can progress, but it's about reassessing it, taking away anything that can irritate your liver as well. So, it's just about sort of being proactive, I would say, both from the clinical team, but also down to the individual.
Yeah, that advocacy again for your own care is really important, isn't it? And again, I would want to re-emphasize that we have a lot of this information. We have a lot of information on our website. It's all been medically checked, so it's all absolutely factually 100% correct. So please do go on our website and have a look for any of the information that you might require. This question is about stem cell therapy for PSC. Is there any?
So the team in Birmingham did have a sort of stem cell therapy. Again, a lot of these studies are done with very small number of patients, and you want to show safety, and they'll look at sort of endpoints which are short endpoints. So blood tests maybe after 12 weeks of therapy or 16 weeks of therapy, but they're a starting point. And what they show is if you can show safety, then you can have bigger studies, sort of larger number of participants, and then it's about showing sort of benefit. Now, as we all know with PSC, it's a long-term sort of game we're looking at, and we're trying to have therapies which will slow the disease down. Obviously, what we all want is to find something that cures the disease. We're not there yet, but all these studies need to be long-term as well, so they take time to do. But I think there'll be more sort of studies looking at different aspects of PSC, the immune system, all these things, and they will come along.
Thank you for that. I'm going to have this as the last question. I think we have answered all the other questions anyway. So it's probably a good time. We are a few minutes to 2 o'clock when we're due to finish. So, been told by my PSC specialist to avoid probiotics, but some studies in the USA have found certain probiotics to be very helpful at slowing down the progression of PSC. What are your thoughts?
So one of my colleagues at King's, Professor Debbie Shawcross, she has done studies not necessarily in probiotics per se, but looking at the gut microbiome and how you can manipulate that with sort of fecal transplant. And that's what essentially probiotics are doing. They're trying to sort of manipulate your microbiome and sort of give you more good bacteria in your gut. So there's got to be I'd say certainly some, common sense would say it can be better. I think you just got to be careful what you're taking. Now, there are certain things you can buy over the counter, obviously, and that's a good starting point. But that could be an adjunct sort of treatment, or something you can decide to do on an individual basis. But we're still trying to understand how we manipulate the gut microbiome and what its sort of importance is in all liver diseases and probably all diseases as a whole. I'd be honest.
Of course, we've got the Fargo trial, which is just recruiting now, I think, or just
Yes.
recruited, which is again the fecal microbiotic transplant. So if anybody's interested in that, please again look on our website. Keep pushing our website today, because you'll see the sites that is recruiting. So that's the end of our questions. It's been a really good session. Thank you so much, Dr. Joshi, for spending the time with us today and answering all of those questions. And thank you so much for everybody who's joined us today. And I hope that you've had the answers. I'm sure you will have to the questions that you've asked. Somebody's sending us a little heart, which has just popped up, which is lovely. Thank you so much for that. Just to let everybody know about the next Ask the Expert session. We run these monthly. And as I said at the beginning, they're available on our YouTube channel. So if there's anything you didn't quite get, or you want to rewatch, or you've forgotten the answer, then this session will be available within the next, we try and get them up as soon as possible, but so within the next week or so, it will be available on our YouTube channel. We'll put it out on our social media that it's available, so you'll know when it's up and running, so you can rewatch the session on that. Our next session is the 19th of February. In the evening, we try to have these sessions at different times, different days, so everybody can, we're hoping that everybody can join them live if they want to do that. So it's the 19th of February, 7 o'clock in the evening. And one of the things we wanted to do in 2024 is provide different types of sessions. So obviously a general session, Q&A on PSC is really important, especially to those who have been recently diagnosed, but to everybody with PSC, because questions pop up all the time and you don't get enough time with your clinicians. So you think of these questions when you're not there. So they're really important. We're still going to have the research sessions. We're still going to have the transplant sessions. We're still going to have what to expect from your care, but we are going to have some different sessions, trialing some different sessions in 2024 as well. The next one is one of those, if you like, slightly different sessions, and that is going to be about managing chronic conditions in the workplace. So we often get asked, you know, what should I say to my employer? They don't seem to see, you know, I look well, but I've got fatigue. How do I explain, you know, things like that. So we are going to take that session. Obviously, everybody's employer is different. They've got different policies, but this general advice about how to manage a chronic condition in the workplace is the next session. It's going to be taken by our HR trustee, Charlene Oakey. So that's on the 19th of February at 7 p.m. We've also having sessions on things like exercise and fatigue in this year as well. So look out for those. But thank you ever so much, Dr. Joshi, again. Thanks everyone for joining us, and we will see you hopefully at another session. Goodbye. Enjoy your Saturday afternoon. Bye-bye.
Take care, everyone. Bye.